This lecture will continue the discussion of NSAIDs. We're now up to propionic acid derivatives, which are a type of first-generation NSAID. These drugs are aspirin-like, but have stronger effects and create less GI irritation. They're better tolerated than other NSAIDs, and gastric upset can occur, but it's not as severe as with other types of first-generation NSAIDs, such as aspirin and indomethacin. Drugs in this group are highly protein-bound, so drug interactions might occur, especially when given with other highly protein-bound drugs. Severe adverse reactions, such as blood dyscrasias, are not frequently seen with propionic acid derivatives. Your prototype propionic acid derivative is ibuprofen. It is the most widely used NSAID. And so that is the one that we're going to have as your prototype for this classification. How does it work? Like the others, it inhibits prostaglandin synthesis. It's used for pain, osteoarthritis, rheumatoid arthritis. Some side effects that we can see, again, gastric distress and bleeding, just because it does play a role in COX-1 enzyme inhibition. I want to watch for tinnitus, dysrhythmias, nephrotoxicity. Again, we're talking about nephrotoxicity. Which organ are we talking about? We're talking about the kidneys. Drug interactions, there's increased bleeding when taken with warfarin. Again, warfarin is an anticoagulant. Increased effects when taken with phenytoin, warfarin, sulfonamides, or cephalosporins. And decreased effect with aspirin. Again, we want to teach our patients not to take aspirin with any other NSAIDs, or take NSAIDs. Mixing NSAIDs would be bad. So in terms of our assessment here, we want to obtain a drug history from the patient and assess for GI distress and peripheral edema, which are common side effects of NSAIDs. We want to let the patient know that their inflammation will subside in 1 to 3 weeks. Again, it's not an immediate thing that we will see. In terms of nursing interventions, because of how the ibuprofen plays a role in blocking or interfering with the COX-1 enzyme, we want to observe for bleeding. So bleeding gums, petechia, ecchymosis, or black tarry stools. We want to tell the patient to notify the physician if they begin having GI discomfort, because we're going to be concerned with ulcers. Advise the patient not to take alcohol or aspirin while taking NSAIDs, and to alert the patient that many complementary and alternative therapies may interact with NSAIDs and can cause bleeding. Fenamates are a type of first-generation NSAID. They work by inhibiting prostaglandin synthesis. Some of the different uses are listed there. The big side effects again are getting to know those NSAID side effects. So GI distress and bleeding. This one we're going to worry about renal dysfunction and elevated hepatic enzymes. So we're going to be watching our kidney and liver numbers there, and avoid if a history of peptic ulcer. Oxicams. For Oxicams, again, first-generation NSAID, meloxicam is your prototype drug that you want to know. It works by inhibiting prostaglandin synthesis. Inhibiting the prostaglandin leads to inhibition of inflammation and pain. Used for osteoarthritis and rheumatoid arthritis. When looking at the side effects, adverse effects there, edema, GI distress, bleeding, renal dysfunction, angioedema. When you see angioedema, a lot of times we're talking about facial swelling. Elevated liver enzymes are also associated with Oxicams. Now we're up to the selective COX-2 inhibitors. So all the medications we've talked about prior to this have been NSAIDs that inhibit both COX-1 and COX-2 enzymes. There's one prototype medication that you need to know as a selective COX-2 inhibitor, and it's celecoxib. It selectively inhibits COX-2 enzymes without inhibiting COX-1 enzymes. So the benefit of this medication, again, is that it inhibits COX-2 enzyme, which means it inhibits inflammation and pain. It does not play a role in inhibiting COX-1 enzyme. So the COX-1 enzyme can go about and do its job like it normally would, protecting the stomach and playing a role in platelet aggregation. So the patient who takes celecoxib, we don't have to worry to the extent as with the other NSAIDs for GI distress and ulcers. right? Because COX-1's not being affected, and also risk of bleeding because platelets aren't being affected. For side effects for a selective COX-2 inhibitor, again, don't associate the GI distress and ulcers with the COX-2 inhibitor. A lot of these medications, you'll see a side effect can be GI distress, but when we're talking about NSAIDs and how they're affecting those COX enzymes, it's the first generation NSAIDs that affect COX-1 and COX-2 enzymes that inhibit both of those that can lead to GI distress and ulceration. So for COX-2 inhibitors, the selective celecoxib, I want you to think again, it's only affecting the COX-2, so it's only preventing inflammation and pain, and does not have the increased risk to the extent of that COX-1 and COX-2 inhibitors for causing GI distress and problems with bleeding. Other side effects for celecoxib or a COX-2, a selective COX-2 inhibitor would be hypertension, peripheral edema, watch for renal dysfunction. So again, monitoring those kidney values would be important also. The use of NSAIDs with older adults, with the use of NSAIDs, GI distress, including ulcerations, is 4 times more common in older adults, and hospitalization is often necessary. So we're going to want to definitely watch. There's a greater incidence of GI distress and ulceration that we're going to want to monitor for. The older adults also often taking multiple medications, so the drug interactions are more common due to the number of drugs that the patient is taking. A reduced dose decreases the risk for side effects, and we want to encourage the patient to increase their fluid intake to make sure that they're having adequate hydration. Now, the medications we just covered were all NSAIDs, or non-steroidal anti-inflammatory medications. We'll just briefly talk about corticosteroids, which is another classification of anti-inflammatory medications. How do they work? They control inflammation by suppressing or preventing many of the components of the inflammatory process. They're used for arthritic flare-ups, not the drug of choice for arthritis because of their numerous side effects. The big thing with corticosteroids is that we want to taper them off. So if a patient's been on a steroid for a while, we don't want to stop that medication abruptly. It would be a medication that they would be weaned off of. And in terms of corticosteroids, this will be a type of classification that you will recognize based on the drug names ending. So if you see it ending in SONE, such as prednisone, which ends in SONE, or if it ends in solone, those would be clues that you're dealing with the corticosteroid. And we're going to talk about this classification of medication in further detail later on.